One of the things that I'm really focused on are clinical trials for MS there, and mainly clinical trials that are involved with targets of the immune system to try to prevent the inflammation that causes MS. We're mainly involved in 3 different areas in clinical trials right now. One area is, like I said, targeting the immune system. So there are different branches of the immune system, and these medications have been around for a long time, but some of the newer medications that we're developing are the oral medications. Prior to the development of oral medications, all of the MS treatments were injectables. And the oral medications are very exciting because not only are they oral, but some of the oral medications work a little bit better than the injectable medications. The additional, more recent developments are medications that target the B cells, which are a branch of the immune system that produces antibodies, and they also are involved in the pathogenesis of MS, and that's a lot of what this meeting has been focusing on as well, is the B cells' role in the pathogenesis of MS. It's been very exciting to do research in that area. Another area that's more new and upcoming is the area of remyelination. So when there's been inflammation in the nervous system, it can oftentimes lead to secondarily demyelination, and that's really one of the key pathophysiological mechanisms of MS. And so what happens is that when there's been inflammation and demyelination of the axons, there's slower conduction along the axons, so that leads to a lot of the disability that goes along with MS. So these remyelinating agents are being developed that will help promote remyelination by the cells in the brain and the nervous system that produce myelin. So that's a really exciting area with the potential for possibly improving MS symptoms. And then the third area that's an area that people are researching and that we want to be involved in is the area of neuroprotection. So the part of the pathophysiology of MS is immune-based, and then there's demyelination. And then because the loss of myelin can sometimes lead to axon degeneration, there can also be neuron degeneration as well from the inflammation and from the sort of oxidative stress of demyelination. So these neuroprotective agents are designed to help prevent that loss of neurons and brain atrophy that can sometimes happen in MS. Those are really early in the stage of research, but we plan to be involved from the very beginning. Yes, absolutely. So in my experience, I started taking care of MS 10 years ago, and at that point, there were still some people who hadn't been started on treatment early, and I saw how much disability accumulated over time without treatment. And then by the time we had immune treatments available, it was sort of too late. So I've seen a big difference since the immune treatments have come out, and especially some of the newer immune treatments that we have, that we can really stop MS in its tracks and get some improvement in long-term disability. So I see a lot more patients in my clinic, for example, that you would never know have MS, that appear completely normal, are not in a wheelchair, are doing very well. And I think that we're understanding more about the differences in each individual. Some patients have very aggressive disease courses, other patients have very benign disease courses, and then there's a lot in between. And the more we understand about that, the more we can target which patients need to be on the aggressive treatments from the get-go, and which patients maybe we can get away with some of the less aggressive treatments. Well, some of the data that was shown today did show that there are distinct differences pathologically when they look at the brains pathologically post-mortem. There are some differences. Secondary progressive MS patients also can still have relapses, so that's a big difference. But really, there are also a lot of similarities in all forms of progressive MS.